Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Maria Jose Soler. She's calling in from Spain. So it's pretty late for her, and I appreciate her coming. She's in the nephrology department at the Vall Hospital in the Nephrology Research Group. I guess the full name is the Vall Institute de Recerca, VHIR. It's part of the Barcelona hospital campus. So, Maria Jose, thanks for coming. How are you doing?
I'm fine. Thank you for the invitation, for inviting me.
Yeah. Tell me about your research. What are you working on?
I'm working diabetic kidney disease and diabetic nephropathy. Actually, I don't know if you know, but diabetic kidney disease is the first cause of end-stage renal disease. So the first cause of our patients ended in dialysis is for diabetes. So I work in the mechanism of the diabetic kidney disease progression, mainly in the renin-angiotensin system pathway. So I don't know if you know an enzyme named Angiotensin converting enzyme 2. This enzyme was discovered in 2000, and I've been studying for years in this enzyme. This enzyme is the one that cleaves angiotensin 2 to angiotensin 1,7. And it's interesting now, and this enzyme now has been famous. I don't know if you know
because
this.
Because of the coronavirus, yeah. That's what it
Yes,
enters through, supposedly, yeah.
Because it's the receptor of the coronavirus in the lungs, in the kidney, in the type of cells that they express ACE2.
So what's the role of the ACE2 receptor normally?
Normally, it's not a receptor. It's more an enzyme. It's an enzyme that catalyzes, for example, peptides, angiotensin 2 to angiotensin 1,7, mainly this peptide, and also catalyze angiotensin 1 to angiotensin 1,9. Actually, we have another enzyme that is angiotensin enzyme named 1, the first that was discovered years and years ago. And people used to say that ACE2 is the good boy, whereas ACE is the bad boy. So if you have, it is expected that if you have more ACE in the organism, it will be worse because you will have more angiotensin 2. That is the peptide with vasoconstrictor, proliferative effect, inflammation. Is a peptide that is needed in the organism but not in excess. And ACE2 is the one that is in charge of the great angiotensin 2 to angiotensin 1,7. So a lot of people have been working in have recombinant from ACE2 for example, diabetic kidney disease, to try to treat patients with diabetic injury with ACE2.
So again, so it's an enzyme. Is it located on the membrane of different cell types, or where is it located?
It's located in the membrane in different cell types. So I was working at my first research started years ago in 2005 at Northwestern University in Chicago with Dr. Vall, that he's the one that has been for years I could say the people that know more about ACE2 in the kidney. And in the kidney, for example, ACE2 is in the proximal tubular cells, and this also in the podocytes, that the podocytes is one of the cells of the glomeruli, and this also in the podocytes. And it's interesting because this enzyme, we discovered that the organ that has more ACE2 activity or more ACE2 is the kidney. You can have ACE2 in lungs, in heart, and in other organs, but the one that has the more this enzyme is the kidney. More expression and more activity of this enzyme.
So the enzyme converts one form of ACE to another, but physiologically, what does that mean? What does it do in the body?
In the body, it seems to be positive, because if you degrade no ACE2 angiotensin 2 to angiotensin 1,7, the function of angiotensin 1,7 is contrary to angiotensin 2. So you have vasodilatory effects, anti-inflammatory effects, antifibrotic effects. So it seems to be positive. For example, one of our preliminary studies was to inhibit ACE2, when they have different compounds that can inhibit ACE2. And we use these compounds in mice, in diabetic mice, and we found that these diabetic mice that we inhibit ACE2 have much more lesions. They have much proteinuria and more fibrosis than the mice that we did not inhibit ACE2. So it seems to have a protective effect in the kidney, for example.
So if someone's sick with coronavirus, is it deactivating a lot of ACE2 enzymes, and that leads to inflammation? Is that one of the possible effects?
I think that someone with coronavirus, and there is some people studying on that, you should increase ACE2, maybe give some external ACE2. It's weird.
Well, why? Because the virus is taking up, it's stopping that enzyme from working? Is that why?
Maybe, or it would be, this will be, I don't know clearly the mechanism, but if you have more external ACE2, I think that it will be protected. How? I don't know, because it's the enzyme. I understand your question, because it's the enzyme, but I think that increased ACE2 will be positive in this disease.
I've heard when people have a heart attack that the remaining tissue will, upregulate ACE2 and it'll be expressed tremendously. Maybe it's a way to save someone's remaining heart. I don't know.
Yes, that's right. We perform our work with, I don't know if you read that, with Hospital Universitario in Barcelona with cardiologists, and we measure ACE2 activity. But I think that this is a protective mechanism. I think that the body understands or have the impression that you have too much angiotensin 2 when you have a heart attack. So ACE2 is needed, and this form of ACE2 is to try to degrade the angiotensin 2. I have this feeling, but ACE2 is a young enzyme. This year is the 20th anniversary of the enzyme, and we don't know all. I don't know if we have different forms, a truncated form that is in the circulation, and a different form that is within the kidney. We are not sure of all of that.
Do you know why people say, again, I've heard many articles seem to say that ACE2 is a receptor and not an enzyme, and that's how the coronavirus enters human cells. How could it be considered a receptor instead of an enzyme? Do you have any speculation on why or how that could happen?
Actually, I think that it's helped for a serine protease, and it could be another form of ACE2 linked to a serine protease that is helping to introduce the coronavirus. But we need to study much more about that. We are in an early phase, and for me, coronavirus is new. I think that we need to know how is ACE2 in lungs with people from coronavirus. We have some stainings, but not definitive results. How is this ACE2 in the blood of people from coronavirus? Is different. We do not know. We need to study all of that.
So your particular research is working with these enzymes to understand how kidney disease occurs in diabetes, or what is it?
And this enzyme is upregulated in kidney disease. Is upregulated in the proximal tubuli of kidney disease and in the circulation of people with kidney disease, but is downregulated in the glomeruli. So it's a difficult enzyme, and the problem, I think, that is when it's altered. I think that ACE2 H2 and ACE, the two enzymes, needs a balance. When this balance is modified, so you have the lesion, no? And this has been our study for years. And for example, we have discovered that one of the vitamin D agonists were capable of increasing ACE2. And I think that increasing ACE2 might be a positive mechanism effect. So we treat diabetic rats with paricalcitol, that is a vitamin D agonist. And we discovered that with this treatment, ACE2 was increased, So we have been studying the modifications of ACE2 within the diabetic kidney, within people with diabetic kidney disease, and if some treatments were capable to modify it.
Well, just to go to a basic level, how does kidney disease start? What does it look like? What happens to cause kidney disease early on in someone with diabetes?
We know that the first phase of diabetic kidney disease is the glomerular hyperfiltration. And recently, SGLT2, we are also studying SGLT2. I don't know if you know this kind of drugs, sodium glucose inhibitor co-transporters. And recently, this type of inhibitors, SGLT2, have demonstrated to be very good for the treatment of diabetic kidney disease. And I think this is because they are acting at the first stage of diabetic kidney disease. When you have hyperglycemia, you have secondary hyperfiltration. And diabetic kidney disease starts by hyperfiltration. I don't know if this was...
okay. So the body is forced to filter out more sugar constantly than it normally would, and that puts strain on the very fine, small filtering elements of the kidney, right?
Yes, but actually, I think that the problem is that when you are urinating sugar, your body increases the expression of the SGLT2 co-transporter, and this co-transporter is taking from the tubuli to the lumen, is taking glucose and sodium. This makes that macula densa, that is later on, sense that you have few sodium and alerts as when you are dehydrated, and it makes hyperfiltrating. This is one of the mechanisms where diabetes starts. I'm sure that we have more mechanisms. This is not the only one, but I think that this is the first one. For these reasons, in 2016, SGLT2 inhibitors demonstrated that were really, really good for the treatment of patients with diabetic kidney disease. And this year, and very important study with canagliflozin demonstrate that this really good in patients with advanced kidney disease.
Yeah, I've heard about these new inhibitory drugs. Just to continue, so the body will, you'll excrete sugar in your urine, but the body you'll also excrete a lot of sodium. So your body thinks you're dehydrated. And then what is hyperfiltration? What does that mean?
Less
what
sodium.
happens?
Less sodium.
Okay.
Less sodium.
It'll conserve sodium because it thinks you're dehydrated.
Yes. It will conserve sodium. You have low sodium levels. That is the typical when you have acute kidney injury because you have dehydration. You don't have water access, or you have diarrhea or this kind of disease. And the body, the mechanism that it performs is increasing hyperfiltration. This is a mechanism of defense of the organism to not lose more water. And diabetes starts on that way. It's difficult to understand. And this makes to activate the renin-angiotensin system. For this, I think that SGLT2 and the renin-angiotensin system is linked. And there have been studies in that topic also.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
All right, so I'm trying to get more of a picture. So what in particular are you trying to figure out? You're hoping to upregulate or increase ACE2, and you think that will have it will reduce the inflammation? I mean, what do you think the effects will be if it's successful?
It has been published. Dr. Vall published in Kidney International a couple of papers demonstrating that a regulation of ACE2, for example, if you have an animal model of transgenic hyperexpression of ACE2 in the podocyte, you have, when this mouse turns to be diabetic, you have less lesion, you have less podocyte loss, so it's expected to have less lesion, less inflammation, less fibrotic effects. The problem is that until now, the recombinant that people have for ACE2, the mechanism for ACE2 amplification, do not last long time in the organism. And a part of ACE2, I think that they are another mechanism. So I'm trying to discover new mechanisms, not that one linked to SGLT2 and ACE2, to try to discover novel therapies that could avoid the diabetic kidney disease progression. Because I don't know if you know, but classically the renin-angiotensin system blockade, but from years ago, studies from Lewis, Brenner, demonstrated that the blockade of the renin-angiotensin system protects against diabetic kidney disease. But this is not enough. People keeps going through dialysis, no? The diabetic kidney disease keeps progressing. So I think that SGLT2 will be one therapy. I don't know if finally we will have some kind of ACE2 agonist that could have a positive effect, but I'm sure that in a next future, we will have new therapies and new mechanisms. Maybe we will not act only in one system. We will block 2 or 3 to avoid the disease progress.
Yeah, what does the disease progress look like from the kidney's point of view? What happens first, and then what happens later on with end-stage renal disease?
Okay, I can explain you. First, we have hyperfiltration. After that, there is an increase in urinary albumin excretion. And in that part, it starts to be worse because this is linked with more cardiovascular risk, cardiovascular disease, myocardial. If you have increased albuminuria, you are at risk for a heart attack, for a stroke. This patient increased the risk of cardiovascular event outcome. And after that, creatinine starts to rise. This is a period of 10, 15 years ago. It's not fast. It's coming. It's a slow killer, a slow killer. And at the end, you finish with end-stage renal disease and dialysis. And dialysis worsens clearly your quality of life. If you are a patient and you need peritoneal dialysis or you need hemodialysis, you can have home dialysis or hospital or center dialysis, but your quality of life is worse. Your prognosis is worse. And the other option that you have is kidney transplantation, but you need to take immunosuppressive therapies. So this is the worst scope, the end stage, the chronic kidney disease stage 5. And I think that you have to avoid this because it's expensive and the quality of life of the patient is clearly worse than previous, not only having a little of chronic kidney disease.
Yeah, I have a friend that's on dialysis and they have to go like 3 times a week and sit there for hours. And if it's not done right, they get very tired and it's very difficult,
You need an access for doing the dialysis. Sometimes this access didn't work or, it's tough. And I think that for people, it's better not to be in dialysis. For example, in Spain, it's interesting that 1 of each 4 of the patients that started dialysis have diabetes. Is high. I think that this is a high ratio. And in America, I think that is worse because you have much more diabetes than in Spain for sure.
Oh, so you said in Spain, 25% of the dialysis patients have diabetes as well?
Yes, between 20 and 25. It depends in the year, between 20 and 25%. Okay. So stop this, avoid then the stage renal disease. For example, SGLT2 now are recommended early on in diabetic patients. If they tolerate that, we are now giving double therapy, renal angiotensin system blockade and SGLT2 inhibitors. Nephrologists are treating with that. And if we have a new drug and we know that this drug delay the progression, we will treat them with that, because as you told me regarding your friend going to dialysis 3 times a week, when you finish dialysis, it's like you have done a kind of marathon or running, you are really tired, you need to recover 2-3 hours. Of course, your friend explained you these problems.
It eats up your whole day. And if you have to take off a lot of water, sometimes you feel sick, and it's very difficult every time you have to go.
You cannot, and if your kidney is not working, you cannot drink. Not only water, coffee, you can only drink half a liter and the quantity that you are urinating. So it's tough for the people, I think. And you need a special diet with low potassium in your diet, because normally the potassium is eliminated by the urine. And if you are on dialysis program, you cannot eliminate the potassium. So you need a special diet that when I explain to my patients the diet, I feel horrible, You have to boil 2 times, take the water off. You cannot eat tomatoes, chocolate. It's almonds. It's difficult. It's really difficult, no? Not only the dialysis, the diet, the not water stuff. If you want to go to visit a country, now we are in coronavirus and it's not time for visiting, but we are hoping that in 1 year, maybe 1 year and a half, we will have the vaccine, I hope so. And our life will modify again. So if you are on dialysis program and you have to go to visit to your family to another country, you need to contact to another dialysis center, for doing your dialysis program. So it's difficult, I think that it's good to try to have some therapies to stop this progression for sure.
Yeah, definitely. Well, very good. Maria Jose, what's the best way for people to find out more about your work?
I think that they can read my papers, and if they have some doubt, they can connect myself, or they can look at the university. Actually, we publish a lot of scientific papers, but we do not do a lot of news. Kind of news for the news. We do not have this, we do not explain a lot our research. But I think that is good that people know what we are doing. And another thing that I would like to explain you is that normally people think that I'm a medical doctor and my background is to visit patients. I'm a nephrologist, And a lot of people think that the nephrologist is involved in research in basic science, because I've been working with podocyte, tubular cells. We are not interested in patients. And this is not true, because actually I love to visit patients. And a lot of my ideas sometimes my research ideas come out from visiting patients, Sometimes I'm visiting a patient and I say, oh, this is really weird. Maybe we should check how many patients have this, or what can we do for them. I think that the combination of medical doctor and researcher is good.
Yeah, definitely, because then you can see exactly what happens with people in clinic, which a researcher, won't see. So it's very powerful to do that. That's excellent.
Yes, and I love it. And another problem that we have with chronic kidney disease and nephrologists is that people do not know our specialty. I think that the best specialty in the world is nephrology, for sure, but people do not know what we are doing. No, sometimes they think that I'm surgeon, that I used to do surgery. Now, nephrologists I can explain if you want. We used to do we used to take care of patients with acute kidney injury. Acute kidney injury is good because it used to be reversible, so we treat the patients and they can recover. Sometimes they have what we name it a scar, no? In Italy, there is a good researcher, a really good research that discovered that when you have an acute kidney injury, after that, you have a lesion and never will be the same, but at least it could be recovered. We treat patients with chronic kidney disease. We manage the patients in peritoneal dialysis, the patients in home dialysis, that now home hemodialysis has become more important after the coronavirus because you can do dialysis at home and you do not need transportation. We follow in Spain. We take care of the transplant in the kidney transplantation program. That I know that this is not the case in America, but here is the case. And we follow the immunosuppressive therapy of these patients. So I think that nephrology is a really good specialty, and you can do. We also have a kind of. We place central venous catheters in the patients. Is performed by us. We also learn how to do ecography. I can diagnose an acute. I can diagnose if you are an obstructive problem. So I think that is a really complete specialty. We manage some patients like internal medicine. We can take care of our patients with pneumonias, with systemic disease, with lupus nephritis. So I think that is a really complete specialty that I'm happy for that. You know, I enjoy my life when I'm working. This is good.
Oh, that's great. I'm glad you're passionate about helping people. So, well, very good. Maria Jose, thank you for coming on the podcast.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.